Hello, everyone, and welcome back to another session with Dental Shadowers. Today, we have a very exciting session with Dr. McCann. Dr. McCann, thank you so much for joining. And on
Hi,
that note,
thanks
the
for
floor is
having
yours. Take it
me.
away.
Sorry I'm a little bit late here. I appreciate everyone's patience with that. So I'm Dr. Katie McCann Lee. I'm super excited to be doing this with you all, and I hope that I can add some value for you guys today. So today we're going to be talking about general dentistry. So I graduated from University of Illinois in 2010, and currently I am a partner in over 85 different practices with Pacific Dental Services. So I know you've had some other speakers on here, so I am affiliated with Pacific Dental. And over the 11 years I've been with them, I own over 85 practices. I also am the clinical director and clinical partner of 5 different regions within the organization. So the organization goes all the way from California to the East Coast. And so I'm involved in South Florida, Central Florida, Georgia, Colorado, and New Mexico. So very, very busy. I also spend my time coaching and mentoring new graduates. What I focus on is trying to make them successful earlier. So we want to increase or decrease the ramp time for new graduates coming out of school to being successful. I also have an implant placement surgical course that I created, and I partner with Nobel Biocare. So I do teach implants as well to general dentists. And then you can see my social media handle is right there, as well as my website. So my journey to becoming a general dentist. So everybody always asks me, what motivates you? Why did you get into the field of dentistry? Because, you have to be pretty much a special person to be a dentist and to do what we do. The job is very, very stressful. It's long hours. And we're constantly working on patients who tell us that they don't like us, right? So I have a very personal why as to why I got into dentistry. So when I was 14 years old, I lived in a small town in central Illinois, and I grew up riding four-wheelers or ATVs. And one night, July 5th, 1998, I was involved in a four-wheeler accident. So it was the only time that I didn't have a helmet on, and I crashed into a telephone pole. So you can see this picture on the left of the screen here. This was me right after I got out of the hospital. So I was in a coma for 5 days. And the doctors told my parents that when I woke up, I was probably not going to be the same person. I was going to have brain damage, and I probably wouldn't remember anybody. So that was fiercely motivating, right? So I ended up breaking every bone from my eyebrows down. You can see my eye socket there was completely destroyed. My lip was ripped off, and I shattered my jaw. So my jaw was wired shut for 2 months. So the problem is that after they unwired my jaw, and I broke my wrist, my right wrist too. So I had 2 months of several surgeries, and after they took my wires off, I was so excited to eat. I wasn't able to eat at all. You can see how thin I was. They cut the wires, and I couldn't open my mouth. And so it took us 4 years and 9 reconstructive surgeries on my face to be able for me to open my mouth big enough to put a toothbrush in there. So you can see the picture on the right of my screen. This is when I was going through all of my reconstructive jaw surgeries. So what they ended up having to do is I had my upper and lower jaws rebroke twice. And then they actually took my right condyle out, took my rib bone, and fabricated it into a TMJ joint. They used cat tissue, cat cartilage to formulate a TMJ disc, and it took several years for that to heal and to reshape. And obviously, the night of my accident, I had lost several teeth, and they were able to put my teeth back in, all but 2. I was missing number 10 and number 23. Which I ended up being really thankful for, because when my jaws were wired shut, I wasn't able to eat at all. So I had this like little passageway there between 10 and 23 that I could put a straw in to have my food. So it actually was a blessing to lose those teeth. But after my wires were removed, I couldn't brush my teeth for several months, and then I couldn't open my mouth for several years after that. So my teeth really took a beating and didn't fare too well. So Throughout that time, I had a lot of oral pain. I ended up having several root canals, several crowns, several failed root canals, apicos. I had tissue grafting, and then I have 3 dental implants as well. So what ended up happening was during the time that I was going through all of my reconstructive surgeries, I was too young for dental implants, right? I was in high school. So, and they didn't want to do anything permanent until we knew that my surgeries were done. So I had to wear upper and lower flippers or stay plates for 4 years in high school. And, you know, I have to tell you, it was absolutely mortifying. There were several days that I would show up to school and my friends would come to my locker before class or before homeroom, and I would turn around and smile, and they would say, "Katie, you forgot your teeth." And I'd have to, you know, quick run to the office and go call my mom to bring me my teeth. It was so humiliating. So I understand what it's like for patients to, number one, be in dental pain, and number two, be, you know, unconfident or humiliated or whatever you want to say about your smile. So it wasn't until my senior year, after all my surgeries were done, I was finally able to get my dental. I got a dental implant on top, and then at the time I had a bridge on the bottom, because they couldn't do block grafts at the time. And I remember going to the mirror and smiling for the first time and actually feeling like myself again. And so I'll never forget that feeling. I get warm just like thinking about it now, but I remember that day it just clicked. I said, I want to be able to do this for other people. So I have a super strong why as to what drives me in my day-to-day business. Let's see here. There we go. All right, so what is general dentistry? So I decided, you know, in school, I did very well in school. I was top of my class. I did very well on all of my exams. And so at the end near graduation, all of the instructors kept saying, you know, what are you going to specialize in? And to me, that was a funny question because I said, well, why do I need to specialize? And they said, well, you're doing so well in school. You know, all the top students are the ones that typically want to specialize. And I said, you know, I want to be that person that can provide excellent clinical care to any patient that walks through my door. I don't want to be limited to just being able to provide one service for patients because, you know, in my hometown, we only had one dentist there. We didn't have specialists. So to me, my dentist was my hero. And so to me, I thought that, you know, since I had studied so well and I had performed so well on tests and in school, that I should focus on general dentistry. So what I really love about general dentistry is it can be literally whatever you want it to be. You can focus on bread and butter dentistry. So you can do fixed and restorative and removable if you'd like. You can focus on modern dentistry. So using proven technologies to better serve your patients. So things like CAD/CAM dentistry, CBCTs, things like that. You can focus your practice on sleep and TMJ disorders. I do quite a bit of obstructive sleep apnea treatment in my practice right now. You can do cosmetic dentistry, which is a lot of people's favorite place to focus on. Implants are another fun one. You do not have to be a specialist to place implants. And, you know, when patients come into the practice with a broken tooth, guess who they see first? It's you, the general dentist. You're the one that's providing the referral for that implant. So that's why I'm super passionate about general dentists placing implants. Plus, I have implants myself, so I know how beneficial they are. You can also focus your practice on the mouth-body connection. So as more research is coming out, we know how important the mouth-body connection is for patients' overall well-being and mortality. We had a call this afternoon with a neurologist who actually gave some really great information. He said the number one cause of cognitive decline is actually sugar and refined flour. The number two cause of cognitive decline is oral bacteria. So there's tons of research right on the forefront here that we're just starting to open up. And as dentists, you can treat that. And then some dentists like to do aesthetics and injectables as well, such as Botox and filler. I actually do that in my practice. I do it for cosmetics, and I also do it for TMJ treatment. Obviously, that's something close to my heart since I've had nine TMJ surgeries, so I know what TMJ pain feels like. So what I really love about general dentistry is you can literally do anything and everything during the day that you want to focus on. Sorry, my mouse is so touchy. There we go. Okay. Oh, Apple. There we go. So advice for college students. Do you know how to just scroll with the keyboard by chance? It's
I
not
think
letting
if
me.
you click the space bar.
Oh, it helps. Okay. See, this is why I need young students. You guys are smarter than me. Okay, so some advice for college. People always say, what did you focus on when you were going through dental school? I always used to hear the saying, D's get degrees, right? And I never liked it when people said that because it's so important to learn everything that you can now, because trust me, it will come up later. And so my advice is study hard. Don't try and just, squeak by and get that diploma. It's really important that you put forth your best effort, because putting forth your best effort now will guarantee that you put forth your best effort in practice and for your patients. I always tell people to practice anything and everything that you can do. Don't just try and focus on getting your requirements done. If there's a super cool procedure that you have the opportunity to try out, give it a try. The more you practice, the better you're going to get. It takes 10,000 hours, they say, to become an expert at anything. And so, start practicing now so you can refine your skills for when you get out in private practice. You also want to time yourself and increase your speed. In school, you see one patient in the morning and one patient in the evening. And patients are very, very patient with you when they come to the dental school. But when you're in private practice, and time is money, not only for you, but for the patient. And so if you can reduce the time that it takes to complete your dental procedures, you'll make your patients more comfortable, you'll make them happier, and you'll also obviously make more money for your practice. I also really encourage the next point: make mistakes. This kind of sounds counterintuitive, but make mistakes while you're practicing under someone else's license. So I used to try crazy things when I was in dental school just to see what I could get away with, to see what would work and what wouldn't work. My senior year of dental school, I had all of my requirements completed. And so I used to sneak down to the oral surgery department, and I made friends with the chief resident, and I used to convince him to let me drill the osteotomies for implant placement. So I would drill the osteotomies and he would actually place the implants, which is, kind of counterintuitive if you think about it, because the implant only goes into the hole that it's drilled. So you think he would have let me place the implant instead of drill the osteotomies. That probably would have been safer, but either way, it was a really good experience. I used to also go into the perio clinic, and I would assist on osteosurgeries and crown lengthening surgeries, just to get more exposure. I'd really encourage you guys to start working on your patient communication skills, because this is going to lead to case acceptance. I felt like when I was in school, I got really good education on diagnosis and treatment planning. I was pretty good at my clinical skills. But one thing I lacked on coming out of school was my communication skills. And it doesn't matter how good of a dentist you are, if you cannot communicate effectively with the patient, no one's going to accept your dentistry. So no one will ever see how good of a dentist you actually are if you can't get them to accept your treatment. So really start to work on your communication skills. A guru in the field of this is actually Dr. Paul Homily. So I've taken several of his courses. He has several books out there on case acceptance. One I think is Getting to Yes is by him. So it'd be really good for you guys to start reading books like that. I would really also encourage you to begin your leadership development. Again, it's dentistry is the easy part. Believe it or not, when you get out, dentistry is the least of your worries. The more difficult thing that I do day in and day out is figuring out how to lead a team, figuring out how to lead patients, and figuring out how to make doctors more productive and efficient. And the way that I do that is by developing myself as a leader. So every way that you approach patients or approach people is going to be different depending on how that person responds to feedback and coaching. So it's important for you to have a well-rounded set of skills to deal with other people. Seek outside information. So I'd hate to break it to you guys, but dental school isn't everything. Dental school teaches you the fundamentals, which is absolutely crucial to successful and safe practice. But there's so much information and there's a million ways to do dentistry. So seek information and seek advice from mentors that you can find outside of school so you can start learning how to practice. And then my favorite thing that I tell people all the time, if you want to be successful in this profession, you have to be humble and hungry. Humble enough to receive feedback and seek feedback, humble enough to know you don't know everything, and then hungry enough to and I always call it grit too. You got to be hungry and you got to have grit to go out and want to succeed. So what does a typical day look like in my practice? So I have several offices, obviously, that I own, but I practice mainly out of 2 offices. And those offices are fairly busy. So we average between $475,000 and $500,000 a month in production. So I have 3 general dentists that work. I have 2 hygienists that work, and then I usually have 1 specialist in my practice. We have an endodontist, an oral surgeon, and a periodontist that rotate through multiple times a month. So at any given day, I probably have 1 specialist there. I see 4 columns of patients myself. My associates see 3 columns of patients. And the way that my schedule is run, I usually have 2 columns for new patient and production appointments. And then I have 2 columns for recall patients and non-productive appointments, such as crown deliveries or denture adjustments, post-ops, things like that. I always try to aim to produce more than $5,000 a day. I typically range between 6 and 7 when I'm in the practice. My associates typically range between 3,500 to 5,000. I'm seeing between 10 and 12 patients a day. So I don't like to do a ton of patients. If I get beyond 12, it tends to become non-productive because I'm running around with my head cut off and I can't get anything done. But if I see less than 10, then I'm really not being as efficient and productive as I could be. So my sweet spot is between 10 and 12. One of my associates, his sweet spot is 8. My other associate, her sweet spot is 12. So every doctor is different. It just really depends on how you work. I do all different types of procedures. So I usually operate out of 4 or 5 chairs at a time. I may have an implant in one room, a new patient in another room, and a crown in another room going. It really just depends on what walks through my door because I tend to focus on same-day dentistry. So if you look at my schedule, it's different than typical private practices because I don't focus on booking my schedule out. To me, if my schedule is booked out more than 3 days in advance, I need to hire more doctors for my practice because it means my patients don't have access to me quick enough. So if one of my patient calls and says, Dr. McCann, I have a toothache, I want to be able to get that patient in today, tomorrow, the next day. And if I'm booked, then that means they're going to go somewhere else. And I truly feel that I'm a pretty decent dentist and I don't want my patients going elsewhere. So I tend to hire more doctors so that we can accommodate more patients. So again, whatever walks through my door, if I treatment plan it and the patient says they want to do it, I find a way to get it done same day. So it makes the days quite interesting when you have multiple procedures going on at one time. So what are the kinds of problems that patients present with? So what I'm going to focus on today is actually the mouth-body connection. So I'm super passionate about this right now. I've been focused on this for probably the past 3 or 4 years. Inflammation is the root of all disease, right? And heart disease is the #1 killer of patients in the United States. So the #1 thing that patients present with in my practice is actually oral inflammation or periodontal disease. Again, like I said, inflammation is the root cause of all major disease that we know. And so it's our job as clinicians to identify this because patients typically see their general dentist more than they see any other healthcare provider. Especially during COVID, patients couldn't get in to see their provider If they had something urgent, they were told to go to urgent care or the ER. Primary care providers were not seeing patients. They were just doing telemed appointments. So it's important that us as healthcare providers, we're starting to identify inflammation and identify risks for systemic disease and make appropriate referrals. So the leading causes of death in the United States, like I said, heart disease is number one, cancer is number two, lower respiratory diseases such as COPD is and emphysema, those are number three, stroke, Alzheimer's, and diabetes. And the thing that brings all of these together is actually inflammation. And so we know that oral inflammation definitely affects all of these systemic diseases. So there's different causes of inflammation. So like I said earlier, a major cause of inflammation is actually sugar and refined flour. Other causes of inflammation are bacterial, the carcinogenic bacteria, endoabscesses, periobacteria. Obstructive sleep apnea is a major cause of inflammation and stress on the heart, which we'll get to in a little bit. Lack of sleep is huge, as well as stress. So this is what I tell my patients all the time. Bacteria in the mouth do not stay in the mouth. Now, when I was graduating dental school in 2010, there was a paper that was published that said there is an association between periodontal disease, heart disease, and diabetes, just an association. And I remember sitting in class and it was kind of like this aha moment, because as dentists, we know that the mouth affects the rest of the body, but we were so excited that finally someone came out and said that there was an association. Well, now it's no longer an association. It is proven and it's causal. So this is super important for us to be educating our patients. And the easiest way that I explain it to them is, okay, patient, the bacteria in your mouth does not stay in your mouth. It actually enters the bloodstream. So the way that happens is we get bacteria and tartar that attaches to the roots of the teeth. It causes inflammation. That inflammation leads to tissue destruction. Once we get a breakdown of that epithelium, that bacteria then emerge in that or integrate into that epithelium, enter the bloodstream, and start circulating throughout the body. One other thing that I see a lot of is in my patients that have liver disease. So patients that have cirrhosis, patients that have non-alcoholic cirrhosis, patients that are on HIV medications that are really hard on the liver, they oftentimes have a lot of systemic inflammation and oral inflammation, and it's all linked to the mouth. There's statistics out there from Dr. Balin Doneen that say 50% of all heart attacks and strokes are caused by oral bacteria. So this is either periobacteria or endodontic abscess bacteria. I remember reading their book right out of dental school around 2011, 2012. The book wasn't that popular then, but I remember reading it, and I'll talk about them in a minute, but it really changed my whole outlook on general dentistry. Again, heart disease is the number one cause of death. And now we want to intervene early. So the most conservative dentist is the one that intervenes early. So when I was in school and we would see a patient with 4mm pockets and bleeding everywhere, we would just encourage them to brush and floss better. Well, I can tell you over 11 years of practice that almost never happens. Don't want to say never, but pretty close to never. Now we know that if we wait until a patient has 5mm pockets and bone loss, that patient is now in a systemic issue where they're going to have chronic inflammation in their system, and they're going to be at higher risk for heart attack, stroke, diabetes, cancer, Alzheimer's. So it's our job to be preventative and conservative and intervene early. Same thing as if you go to a dermatologist and they see a suspicious lesion, they take it off instead of waiting for it to progress to stage 4 melanoma. So we need to change our mindsets about how we treat oral inflammation. So this is the book that I read that really changed the way that I practice. So Beat the Heart Attack Gene. It's written by Dr. Bale and Dr. Doneen. They have a program out of Washington where they have 100% money back guarantee that if you are their patient, you will not have a heart attack or stroke while you're under their care, which is pretty remarkable. I've never heard of any doctor having a 100% money back guarantee for a healthy life. And what they do is the whole book talks about diet and different tests that you can do and supplements and things like that. But there's a chapter in there about oral health. And so they really started educating their patients about how getting their mouth healthier would help their systemic health. So I actually receive patients from Dr. Balin, Dr. Doneen now, which is, really, really cool. I feel like I've almost come full circle here because I've admired them for a long time. And now, because of how involved I am with the mouth body connection, they're sending me their patients all the way from Washington. So that's pretty cool. So we know that perio-pathogens contribute to atherosclerosis. So we know that there's a causal relation to the bacteria in our mouth and heart disease. The bacteria that are directly linked to heart disease are listed below. I'm not going to try and pronounce all of them for you. You guys can probably do that yourself, but we call them AAPG, TF, TD, and FN. So I always tell my patients, your heart disease is a medical condition with a dental solution or a dental treatment. And this is why medical and dental teams must work together. It's our job to communicate to the patient's healthcare provider what's going on in their mouth. Now, the healthcare providers might not always be fully educated on the link between oral systemic health, but it's still important that you communicate with the medical community so they can start to engage us more and include us in the patient's overall healthcare. We also know that perio-pathogens contribute to diabetes. So patients with perio have an elevated risk of diabetes. So if a patient has gingivitis, so no bone loss, right? They have a 40% chance of increased risk for diabetes. If they progress to perio, it's 50%. Edentulous patients still have a 30% risk, and that's because we still know that perio bacteria are present in the mouth, even when teeth are not present. And for patients with advanced perio and multiple missing teeth, they have a 70% chance of diabetes. So again, if we just focus on that 40% number for patient with gingivitis, we have to pause for a minute and think, why are we not intervening and treating early, right? We want to try and keep our patients from getting diabetes, because once they start missing teeth and have perio disease, it's almost a 1-to-1 correlation there. The call that I was on today was about oral health and brain health. So we have another webcast coming up regarding that. So patients with perio disease are 2.6 times more likely to develop Alzheimer's. Again, straight from the neurologist today, he said the number 2 reason for cognitive decline is oral bacteria. That was shocking to me. We also know that the bacteria in the mouth that's linked to Alzheimer's and dementia is PG. So it's important that we test the patient's saliva to figure out if they have PG and if they have Alzheimer's or dementia in the family. It's really important to know that. So we also know that perio-pathogens contribute to different types of cancer. One of those cancers being pancreatic cancer. This is one that I typically focus on because pancreatic cancer is such a deadly disease, right? You get pancreatic cancer, unfortunately, you're almost always, dead in 5 years or less. So we haven't really figured out a way to test and treat pancreatic cancer earlier. But what we do know is that there's 2 bacteria that are associated with pancreatic cancer, and that's P. gingivalis and AA. So we can also test for these now and treat our patients. And as you guys all know, this is very common knowledge that we have pregnant mothers have an increased risk for preterm birth and stillbirth if they have bacteria, periobacteria in their mouth, and this is due to FN. FN bacteria is also related to 20% of colon cancer cases. So FN is a nasty bacteria. It's super hard to treat. It's very resistant to pretty much anything, but there are ways that we can get FN down. A really cool story with this. So I have a patient who she's older and she has super clean teeth, immaculate oral hygiene. She does have recession, but no pockets. But every time I see her, she's bleeding, even though her gums really don't look that inflamed. And when I started getting into salivary testing, I said, hey, why don't we do a salivary test? Because you do have recession, you do have bone loss. even though you don't have pockets, but you are bleeding. So something's going on here. And I started educating her about the different types of bacteria. And I started asking her about her family history. And it turns out that her mother had dentures when she was 21. And she also had 4 stillbirth babies. I mean, can you imagine 4 stillbirth babies? And then she ended up with my patient, Martha. Martha has 1 daughter, and her daughter she could never get pregnant after that. And her daughter also has the recession and the bone loss. And so I started talking about FN with her. So we did a saliva test on her, and the only bacteria that showed up on the test was FN, and it was through the roof. So just really cool things that we can uncover with our patients. So what are some tests and instruments that we can use? So the biggest thing that I would say is to just probe every patient, every cleaning. So when I was in school, the standard was you probe prophy patients once a year, and you probe your perio maintenance patients every 3 to 6 months, or every visit or every other visit. Now we want to probe every cleaning, because we know that the oral health or the oral environment can change in as little as 90 days. So even waiting 6 months between probing is too long. So if we even wait a year, we may be missing early signs of disease and infection and allowing that patient to cross the line into systemic perio. There's also, in my practice, we don't discriminate on age. So when the patient has a full adult dentition, we probe. So that typically is around age 14 when the second molars fully erupt. And again, what's interesting is I've done saliva analysis tests on kids that have, severe gingivitis, because kids don't brush their teeth all that well. And what's interesting is the bacteria profile that's in the kid oftentimes matches the profile that's in the adult. And the profile it's at the same level. So the adult has levels that are super high, and so does the kid. The only difference is the kid hasn't had bone loss yet. So it's really important to intervene early, even in teenagers. So I use Salivary Diagnostics in my practice, and the Salivary Diagnostics are going to tell me the bacteria levels that are in the patient. It'll tell me the bacteria type that's in the patient and how to best treat it. And it's also going to tell me if they have genetic mutations in their interleukin genes, interleukin 1 and interleukin 6. That's important, because if a patient has a mutation in one of those genes, even if it's a heterozygous mutation, it's going to put the patient at an increased risk for systemic inflammation anyway. So that means if the patient's already going to be on fire, right, on the inside, so any type of bacteria that's in their mouth, their body's going to have an exaggerated response to. So I have to kind of over-treat or be more aggressive for those patients. So my patient Martha that I told you about, she has great oral hygiene, but bone loss and recession and some bleeding, but very little etiology. She had interleukin mutation. So that means that she's constantly inflamed. So we have to treat her more aggressively. Another test that I started doing is the alpha MMP8 enzyme testing. What's really cool about this is specific chairside objective data that I can obtain on my patients. So it's just like a blood pressure reading, a cholesterol reading, or a blood sugar reading. It's little litmus paper strips that I put into the pocket, and it analyzes the level of those enzymes in the pocket. And I'll go into that in just a minute. And again, the reason why I'm doing this is because I want to figure out objectively what's going on in my patient's mouth, so I can create a customized prevention and treatment plan for my patient so that I can prevent long-term destruction and lower systemic inflammation. So this is a salivary diagnostic tool that I was talking about. It's called Oral DNA. The tests that there's several different tests that you can order through them. The Myoperiopat test just talks about, or just will give you the bacterial profile of the patient. So it'll tell you what bacteria are present, the levels they're present, and how to best treat them. It'll also tell you what bacteria is affecting what organ systems. So that's a really cool thing to show the patient. The Alert2 test is the one that I do. It gives me the interleukin mutation information as well as the bacteria. So it combines them. We have HPV testing. So you can actually test for HPV in patients to determine the oral cancer risk. And you can also test for strep mutans as well in kiddos. So here's an example of a Myoperiopat test result. So it breaks it down into high risk, moderate risk, and low risk. So what the patient's going to do is they're going to swish and spit. Sorry, Amazon's here. They're going to swish and spit in a tube, and then you have to send it off. So you won't get these results immediately. So we'll get these results back in about a week, and it's going to break it down into high risk, moderate risk, and low risk pathogens. The high risk pathogens you can see are the red complex bacteria. So that's going to be your AA, PG, TF, and TD. What these mean is that they're going to be very strongly correlated to heart disease, diabetes. You see PG is there, that's for dementia as well. And these pathogens, when they're present, cause a lot of tissue destruction at low levels. Your moderate risk pathogens are going to be more of those chronic perio cases, and these bacteria are going to be very resistant to treatment oftentimes. You can see FN is in this category. And then your low risk pathogens are over there. That's going to be more of your gingivitis and home care. So if I see someone that has high levels of low risk pathogens, I'm going to tell them that they need to step up their home care. But what's really cool about this report is it'll tell you information about the bacteria. So if we look at P. gingivalis here, it says that P. gingivalis is transmittable. So at this point, I'm going to be talking to the patient, hey, I need to test your spouse. I need to test your kids, because most likely you guys are transmitting this bacteria between each other. It's also tissue invasive. So this is important because it means the bacteria is not just going to stay on the root surface of the patient. It's going to invade the tissue, the periodontal pocket, and it's going to circulate the body. That's why P. gingivalis is so indicated in heart disease, diabetes, and dementia. So I'm going to tell the patient, hey, every time you come in, we have to do some sort of therapy for your gum tissue, whether it be laser, Arrestin, whatever you choose, because you have to treat that tissue invasive bacteria. Okay. So it's just important to relate this to the patient. On the second page of this report, it actually will tell you what bacteria is linked to what systemic ailment. So then you can tie it back to the patient's medical history and also communicate that information with the patient's primary care provider. This is something that I love. So when we are doing salivary diagnostics, there's several bacteria that are SRP resistant. So a lot of people think, or patients think, oh, I got SRPs, I'm cured of perio, right? We know that perio is something that they're going to have the rest of their life, and we're going to have to maintain it. The salivary diagnostic data, the report will actually tell you what bacteria are resistant to SRP treatment. You can see there's quite a bit of bacteria on the left-hand side of the screen that are resistant to SRPs. So again, this means that if you were to only treat the patient by doing SRPs, you would never get this patient into a healthy state. You would never reduce their oral inflammation, and you would never reduce their systemic inflammation. It's not enough. So we need to communicate this to our patient. Sometimes we need to give systemic antibiotics. Sometimes we need to put them on a shorter recall. Sometimes we need to get them over to the periodontist for surgery. So it just kind of depends on how they present clinically. We also know that there's tissue invasive bacteria. So that's one that I just went over on the previous slide with PG. So if I have any of these 4 bacteria present in my patient's mouth, I'm always going to be doing adjunctive services to try and lower that bacterial load. So this is the alpha MMP8 enzyme test. It's seeking FDA approval right now. It's being used extensively across Europe. And this is a chair-side objective data test. So I love it because, if a patient comes in and I say, oh, you have periodontal disease, and they say, no, I don't, I can actually run this test chair-side, and they can get a reading, and it tells them how severe or advanced their periodontal disease actually is. So it's super cool. There's 2 different kinds. There's a rinse that you can do, which is a general kind of screening. I don't really like that one because it's not as specific. So instead, I use these little litmus paper strips. You put them in 4 different pockets of the mouth. You combine them with this liquid, and then you drop the liquid onto the stick. It's kind of like a little pregnancy test, if you will. And then you put the stick into this reader, and then in about 5 minutes, it'll print out a report for your patient. And so if I have a patient that I recommend it on all patients because I want to know what level they are. But if I have a patient that's super questioning whether or not what I'm saying is true, or if they actually have perio, or even patients that have been in the perio program for a while and want to see how they're doing maintaining their disease, we run this test on them. And the reason, again, I like it is because it's actual objective data. It's just like getting a cholesterol test. And so what it does is it prints out this reader. So anything above 20 means that you have an elevated MMP8 enzyme level. That the amount of the enzyme is directly related to how much gum and bone tissue you're currently losing and will continue to lose in the future if you do not treat it. This enzyme is also found in the liver. It's also found in the heart. It's also found in our arteries and blood vessels. So that's why I said patients on HIV medications and liver cirrhosis, hepatitis patients often will have really high levels of these numbers because this enzyme is found throughout the body. If someone has a reading between 20 and 60, they have an elevated level of MMP and they need treatment. And then anything above 60 is, fire alarm. We have a major issue right now. We have an acute, active, aggressive infection going on that we need to treat. And so based off of this, we can create what's called a personalized prevention plan for our patients. So you can see here, we wanted to put them on a 3-month recall. We recommended laser. We also do probiotics for our patients, oral probiotics, and then we do nutritional counseling. So this is one of my patients. He agreed to be put on this slide. He was so happy because when he took this test, I had just gotten the technology, but he had been in the perio program for a while, and we had done oral DNA testing on him. His oral DNA testing, he was over threshold on almost everything. He also has a genetic mutation, an IL-6 genetic mutation. He's intermediate risk, which means he's already, on fire systemically. He has heart arrhythmia. It has a pacemaker. He has AFib, and his result was a 23. And he was so excited because that's actually a very good result for someone with his medical history. Most of the time, patients come in, they are 70 plus. So it's pretty shocking to see. I've seen as high as 160 on a patient, and they were in their mid-20s. Something else that I do is sleep apnea. So sleep apnea is something that's super huge. And if you guys can start to learn about this now and learn how to treat it in your practices, you'll be ahead of the curve. Dentists really haven't caught on to this too much yet, but it's a silent killer. There's 22 million people that have sleep apnea, but only an 80% are undiagnosed. So this is where I really see the future of dentistry going. Sleep apnea is directly related to hypertension, heart failure, AFib, stroke, diabetes, depression. That's why people have heart attacks in their sleep. It's because they stop breathing. It puts excess stress on their heart. They have a heart attack and then they die while they're sleeping. We also know that sleep apnea actually is more dangerous driving than it is to drive drunk. So there was a study that came out looking at drunk drivers versus people with severe sleep apnea, and people with severe sleep apnea actually did worse behind the wheel. And so why this is important to dentists is because we are in their mouth all the time. We can see their airway. We know their Malin-Patty score. If you see a patient with a super red throat, an elongated soft palate, kissing tonsils, Malin-Patty class 3, you can't even see their throat when you ask them to say that's going to be a sleep apnea patient. Other things that are directly tied to sleep apnea is if you have someone with severe bruxism, severe wear, TMJ pain, sorry guys, headaches, and then another one is GERD. If I see someone with erosion on their teeth and wear, I'm immediately thinking sleep apnea. So start to think about this as you're in school. So I just wanted to share a couple cases with you guys. These are directly from my practice that I've treated in this past year. So I had a male come into my practice, 25 years old, no significant medical history. He just hadn't been in a couple of years, thought he was due for checkup and cleaning. We did his probings. You can see the measurements below. So he had a 6, a couple 5s, 4s, and 3s. So I took a oral DNA profile on him. And the results came back and I was actually shocked. So he had a ton of calculus, ton of bleeding, deep pockets. So I thought his bacteria levels would actually be high. And as you can see, they're below all of the threshold levels. So those little black lines are the threshold levels. So if bacteria levels are higher than those, for the average population, that means the patient's currently experiencing gum and bone loss. And it also means it's affecting distant organ systems. But you can see he was below threshold on all of them. But what was interesting is his gene marker. He has the homozygous mutation for interleukin 6. So he is a high risk for systemic inflammation. So I know that his system is overreacting to whatever bacteria is in his mouth. So the way that we treated him was we did SRPs, laser irrigation. I did not do a systemic antibiotic because this isn't bacterial. I mean, he does have bacteria, but it's not so much a bacterial infection that's the problem. It's systemic inflammation. So we did nutrition counseling with him, low sugar, no gluten, no dairy, more plant-based, try and stay away from animal products. And then I put him on a 2-month recall because I don't want to allow any bacteria to repopulate in his mouth because I know he's going to have a pretty big reaction for that. And when I was talking to the patient, I said, you're young, you're healthy, you're 25 years old. Does anyone in your family have heart disease, diabetes, or dementia? And he's like, yeah, everyone in my family suffers from that. And so we had a very serious conversation of, you're at high risk for going down that path too. And being 25, I need you to take this seriously if you want to stay healthy. And he does. He comes in every 2 months. Second case here. So a female, 27 years old, no significant health history. So she came in. These were her pocket depths. She had some 5, 6s, and a 7. And when I got her results back, you can see she was through the roof on everything. Super high. She had bacteria that are resistant to treatment. She has tissue invasive bacteria. So the way that I treated her was scaling, replaning, laser irrigation. I actually gave her 2 systemic antibiotics, oral probiotics, Paradex rinse. I told her that at each visit, she's going to have to expect laser and irrigation. And we wanted to retest her as well. So when she came back, we did a retest 8 to 12 weeks later. And this is how she presented after her treatment. So what was interesting was we were able to get all of the high-risk pathogens down, which was great. But as you can see, those moderate-risk pathogens stayed high. And again, remember I said that FN bacteria is a really, really stubborn guy. Really difficult to treat that one. The moderate-risk pathogens, that's where your SRP-resistant bacteria are going to lie. The one effective treatment for FN is actually metronidazole. And metronidazole is a pretty strong, nasty antibiotic. And it came, she did disclose that about halfway through the metronidazole dose, she had to stop taking it because it was too hard on her stomach. So we weren't able to get FN down. But then if you look, the low risk pathogens, the CS is high. So I had to have a conversation with her about how important oral hygiene was, because those low risk pathogens are the ones that form on the biofilm first and kind of serve as the framework for everything else to stick on. So we really had to have a conversation about oral hygiene. And then I got her to the periodontist from here for localized osseous surgery. So those are the cases of or mouth-body connection, oral systemic health that I do in my office. So some advice for future dentists: be ready to work hard. I think sometimes it is shocking. I love new graduates. That's typically who I choose to hire in my practice. And I think sometimes it is a little bit shocking to some about how hard they have to work in dentistry. Always ask for feedback and mentorship. Remember, you're in control of your own destiny. So if you're in a situation and you feel like you're not getting the mentorship that you want or feedback, make sure that you're seeking that out. I tell people this all the time: you must be uncomfortable in order to grow. So if we think of Olympic athletes, right, their practices are not easy. When they go to practice every day, they're uncomfortable, they're straining, they're stressing, but they're doing that because they want to improve. Dentistry is the same thing. You have to be uncomfortable every day in your procedures to grow into a better dentist. Remember that the size of the problem is related to the size of the potential. So I tell my docs all the time, the bigger your problem, the bigger the potential for success. So don't be afraid to tackle big problems. Something that's super close to my heart, find your why and you'll find your way. So figure out why you chose dentistry, figure out what you're passionate about, even within dentistry. So mine is mouth body connection and dental implants. It's something that's affected me personally. So make sure you do some soul searching and find your why. And then just remember the best is yet to come. I love dentistry. I hope I've conveyed that to you guys today. It's an absolutely amazing profession, and I'm so excited you guys get to enter into it. So thank you guys for listening to me ramble on today. Here's my Instagram. I'm always posting cases, implant cases, mouth body connections on Instagram, and then I have a website as well that I post a leadership blog. I post tips and tricks on how to lead teams, and then I also do my coaching and mentorship off of my website as well. So please check them out. If you guys have any questions, I'd be happy to take a few minutes and take some questions or comments.
Yes, thank you so much for your presentation. And we do have some questions from the chat, and I'll be reading them to you.
Sure.
Okay, so the first question is, have you ever ran into a problem where a patient will not believe the Salivary Diagnostics? How do you or how would you try to prove the accuracy and push or guide them to receive support even if they try denying?
Yeah, so I've never had anyone not believe the salivary diagnostic test because it's purely objective, right? The report comes back, it is FDA approved, even the enzyme test. I've never had anyone not believe that. I have had people say they don't care. I've had people say, okay, I understand I have an infection, I just don't care. And that's only been, less than 3 patients. It hasn't been that many. But most of the time, by the time I can get that objective data, they 100% are on board with understanding that they have an issue. When they push back is when you're probing, they say, well, of course my gums are bleeding. You stabbed it a bunch of times with a sharp instrument. Or they'll say, well, you got those deeper pockets because you pushed too hard. So those are very subjective things. So it's so much nicer to have objective data that you can, and test results that you can give to the patient.
Okay. And our second question in the chat is, what is the usual chair time for your production and how long do you spend with new patients?
Great question. So I try and prep as quickly as possible. And any of the dentists that work with me, we train them to prep a crown in under 10 minutes, inlays, onlays in under 5. The reason for that comes from personal. So even though I've had 9 jaw surgeries, I can still only hold my jaw open for about 20 seconds before I'm in excruciating pain. So if I had a dentist, and I have crowns and root canals and implants and all kinds of dentistry, and my dentist was very good and he was very quick. I still have the dentistry in my mouth from the 90s from him. And so that really taught me that patient comfort is everything, right? Patients are more likely to get dentistry done if you can make them comfortable. Nobody wants to be drilled on for 45 minutes. And so it's really important that we as clinicians try and learn tips and tricks to decrease our prep time while still being clinically excellent. We never want to sacrifice clinical excellence for time ever. But you can have both, right? It needs to be an and situation, not an either or. Secondly, the longer you prep the tooth, the more you're heating it up and the more chance for post-op sensitivity. So you want to prep quicker so that you have less post-op issues. And then thirdly, the more or faster you prep, the more dentistry you can do for the patient. And it's really hard to get patients to take off time from work to come in and see you. So if I have a patient say, hey doc, I have 2 hours, I can't see you again for 6 months because I can't get, any more time off work or away from my family, I'm going to try and do everything I can in those 2 hours to get them healthy. So I prep crowns in under 10 minutes, inlays, onlays in under 5. I do use CAD/CAM dentistry, so I can deliver my crown same day. So I typically will have a patient there for an hour and a half to 2 hours, and I try and focus on quadrant dentistry. So I try and do segments of the mouth at a time, just so I can get more stuff done.
Yeah, I totally agree. Sometimes I see that in my dentist office. So And our last question is the mentorship program solely for dental students?
No, so I actually mentor the docs that I mentor are actually practicing dentists. So what typically happens is I'll have new graduates reach out to me and say, "Hey, look, I want to be as successful as possible, or I'm not having success right now. Can you help me?" And so I'll mentor and coach them. Other times I have owner doctors who will reach out and say, "Hey, I have an associate, doesn't have to be a new grad, but I have an associate that just joined. I don't know how to train them. They're not having success. Can you come help?" So it's for everybody. But I would encourage people to wait until they get their license.
Okay. I
So
think that's it. That's
that's
our
all.
last
Okay.
question.
Perfect. So
Great.
unfortunately, it looks like that's all the time we have. Dr. McCann, thank you so much. That was such a unique and informative presentation. And I also want to thank all our viewers for tuning in today's session. To find our quiz, you can find it on our Linktree or our GroupMe. And on that note, I want to thank everyone for joining once again. Thank you, Dr. McCann, once again, and I hope you all have a great rest of your night.
You're welcome.